Alright, let's talk about diagnostic testing for genetic disorders. Some background. 1 out of 150 live births have some kind of chromosomal abnormalities. Half of the miscarries in the first trimester is due to chromosomal abnormality. 5% of stillbirths are a result of cytogenetic abnormality. 5% of infant or childhood death are a result of chromosomal abnormality. Examples of single gene disorders are rare. There are sickle cell, cystic fibrosis, hemophilia, Tay-Sachs. These are just examples. Prenatal diagnostic lab technique. These include traditional karyotype analysis, fluorescence in situ hybridization analysis, or FISH, or chromosomal microarray analysis. So for traditional karyotype analysis, it identifies all aneuploidies and large rearrangements. Not available for up to 2 weeks after sampling. 99% of aneuploidy are large than 10 megabases. FISH analysis available within 2 days, most commonly used as a screening for 13, 18, 21 X and Y, but there it is considered a screening, not a diagnostic test. Chromosomal microarray results less than 1 week can detect small copy number variants. Preferred over karyotype for fetal death cases because it can uses it doesn't need to use live cells. Preferred if ultrasound finding suggests if there's ultrasound findings of structural abnormalities. Invasive prenatal diagnostic testing technique, pre-implantation genetic diagnosis, recommended still recommend routine screening and diagnostic tests later on. CVS can be done between 10 to 13 weeks, needle into the placenta without entering the amnion. Shorter result time versus amniocentesis is usually less than 1 week as opposed to 1 to 2 weeks from amnio. Pregnancy loss rate 0.2%. Limb reduction risk after 10 weeks is the same as general population, which is 6 out of 10,000. There's a 0.5% risk of failure, leaking of fluids, and infection. (0.2%) pregnancy loss rate. Amniocentesis usually done 15 to 20 weeks, but can be done later. You use a 22 gauge spinal needle, and you draw about 225 25 cc's of amniotic fluid. Usually we wait until the amnion and the chorion is fused. Pregnancy loss rate is also around 0.2%. Loss of leaking of fluid and vaginal bleeding in 1% of the patients. If PPROM, the perinatal survival rate is 90%. There is a 0.1% failure rate. So, which patients are at increased risk for fetal genetic disorder? AMA, APA, parental carrier of genetic of chromosome arrangements, parental aneuploidy or mosaicism, prior child with a structural prior child with a structural defect, parental carrier of genetic disorder, previous fetus with aneuploidy, structural anomalies identified by the ultrasound. So obviously AMA is easy to understand. Advanced paternal age, usually defined as 40 to 50. There's an increased risk for single gene disorder, achondroplasia, Alport syndrome, Crouzon syndrome. There's no specific screening for APA. So the rearrangements usually are translocations or inversions. Parental aneuploidy include trisomy 21 women increased risk of having offspring with trisomy. XXX or XYY has no discernible increased risk. Prior child with a structural birth defect, isolated structural defects have a 3% recurrence rate. Prior child with aneuploidy, the recurrence risk is 5 times. Structural anomaly identified on ultrasound. The increased risk is low if it's an isolated soft marker. Maternal infections, hepatitis. Maternal bloodborne infections affecting the diagnostic test. Vertical transmission. Risk of vertical transmission if the maternal blood has some type of infection, such as Hep B. Higher viral load or Hep B E antigen increased risk of vertical transmission after amniocentesis, about 20 times. Hep C, there's low risk. HIV patient on CART have low risk of transmission, and CART should be started before the procedure. For multiple gestations, amniocentesis loss rate in twins is 2% versus 0.2%. Chromosomal mosaicism, 0.25% of amniocentesis results can have chromosomal mosaicism, 1% during the CVS. Likely maternal cross-contamination during CVS or placental mosaicism. We can so this is during CVS. So we can repeat with amnio. There's possible imprinting, Prader-Willi or Angelman.